It's with great pleasure that I introduce Dr. Saad Usmani, who's here and will talk to us about the treatment of relapsed refractory myeloma.
Thank you so much, Leaf, and the Arizona Myeloma Network for giving me the opportunity to come out here and chat with you. So this first slide, I think we've talked a lot about from the first talk onwards. We've talked about a lot of hope. And this first slide, you can see these two pictures. So there is a group of 7 myeloma patients and 6 caregivers that were with me about a week ago, and that's the Mount Everest Base Camp. And when I was starting in the field, this was just a dream. This couldn't have been possible. But due to the work of good people like Dr. Anderson and Dr. Berg-Sagel, and myeloma patients can dream to do normal bucket list items like this. And did I mention that we also raised a little over $400,000 for myeloma research while doing this? And that's my only slide. So getting on point now regarding relapse and refractory myeloma, one of the common questions we get from patients is, what's relapsed myeloma and what's refractory myeloma? Well, relapsed myeloma is the recurrence of myeloma, after a patient has had response to therapy. And refractory myeloma is progressing with disease while you're on a specific therapy, and that's the distinction. And there are patients who may have relapsed and or refractory myeloma. They may have responded, but they are progressing despite ongoing therapy as well. And I'll share a little secret with you. I think that's on the next slide. No, the slide after that. So there was a time when as a fellow, I used to give this talk. There were only 2 or 3 options on this list. But now we have a lot of different drug classes available for treatment of relapsed and refractory myeloma disease. The immunomodulatory drugs and the proteasome inhibitors have been the mainstay for the most part. Old-fashioned chemotherapy drugs, including anthracyclines and alkylators, are still somewhat part of the myeloma therapy, but we're hoping that as we continue to develop newer drug classes, that we can potentially eliminate them. Steroids are, there's a love and hate relationship between steroids and myeloma patients. It's a double-edged sword. It does have anti-myeloma activity, but it does have a lot of short-term and long-term consequences that myeloma patients want to avoid. But there's still a very effective treatment modalities. HDAC inhibitors are there in the clinic, and then more recently, monoclonal antibodies such as elotuzumab and daratumumab have come into the clinic. And Dr. Anderson is going to talk in more detail about all the wonderful immunotherapy strategies that are in the works in the clinical trials arena. So this is that slide that I was going to mention. I'm going to let you in on a secret that all myeloma doctors have. So when we're thinking about choosing treatment for myeloma patients, we actually have this figure as a dartboard in our office. No one can see it. It's behind our office door. So when we're seeing patients, as we scurry out of the clinic and into our office, we close the door and we go like this, and then we just throw a dart. But this schema is real. There's a lot of thought that goes on in deciding treatment for a myeloma patient in the relapsed refractory setting. And a lot of that decision making has to do with different sets of factors. But you guys are at the center of that decision making and are equal participants in it. So what are we thinking about as we think of choosing different treatments for relapsed refractory myeloma patients? What do we know about the patient's myeloma? What prior therapies they had, what kind of response they had to those treatments, what kind of side effects they had to those treatments. And as the myeloma is relapsing, our patients, their disease biology, is it the same, or have they picked up, has the myeloma picked up more karyotypic abnormalities or any gene mutations? So those are the kind of things you're thinking about when you're thinking about the treatment history as well as disease biology. And then what do we know about the patient? The age, other comorbidities. Since the time of diagnosis, a patient may have picked up other comorbidities along the way. And are there any long-lasting side effects from previous treatments, such as peripheral neuropathy? Or were there any serious blood clots that happened in the patient's previous few years with treatment? And then what are the personal preferences and values patients have? This is extremely important. So all of these things go into play when we're thinking about treatment history. And so we divide the treatment selection based on disease-related factors, prior treatment-related factors, as well as patient-related factors. And when we sit down with you, we discuss the different options based on these things and then come up with a game plan together. Options, when you're thinking about, again, relapsed refractory disease, they continue to increase. So the longer patients live, people like us, we are working really hard trying to develop newer drugs and newer combinations and present those options for you. So the things that we think about, when do you relapse from your initial therapy? Is it under 6 months? Well, if it's under 6 months, then you have to think about a different treatment option. Give non-cross-resistant treatment to patients, and also think about stem cell transplant. And Dr. Krishnan went into more detail about which patients would be appropriate for that option. If patients have had treatment for and have had benefit from treatment for over 6 months, then one can actually repeat the initial therapy with some modifications. One can also try a different therapy in addition to what patients got, and stem cell transplant may also be an option. But at the heart of it, what people like me do is we're thinking about clinical trials first for our patients, and then some of these off-protocol or commercial options. Being a multiple myeloma research consortium member, we are able to offer a lot of clinical trial options to our patients. In terms of commercial treatment options, I showed you this table with the different drug classes. We can combine several of those drugs, such as bortezomib, along with one of the immunomodulatory drugs, or carfilzomib, along with immunomodulatory drugs. And then drugs like elotuzumab, called Empliciti, ixazomib or Nilaro, or daratumumab or Darzalex, they can be combined at the time of first relapse. Patients who are beyond that first relapse, the options that are available include daratumumab, pomalidomide, as well as the HDAC inhibitor, Farydak or panobinostat. And over the next few slides, I'm going to go over each of these drugs and just share with you how they're currently approved and utilized for myeloma patients. So going on to the first proteasome inhibitor, carfilzomib or Kyprolis. It's currently approved for use either on its own along with dexamethasone or with Revlimid and dexamethasone for relapsed and refractory patients. It's given intravenously. It's given on 2 consecutive days every week for 3 weeks, and then the 4th week is off. Generally, when patients are on proteasome inhibitors like carfilzomib or Kyprolis, they are receiving shingles prevention pills called acyclovir. And if they're receiving Revlimid or immunomodulatory drugs, then they need to be on blood thinners. And I think Dr. Burke-Sagel covered that as part of his talk. The potential side effects include fatigue, anemia, nausea, low platelet numbers can happen during the cycle. Shortness of breath can occur, hypertension can occur, and then one has to be careful about the risk of worsening cardiac symptoms, which can happen in maybe 5 to 6 out of 100 patients. So we have to be mindful of those symptoms. Then we have Ninlaro or Ixazomib. There's an interesting story about the name of this particular proteasome inhibitor. So this, the name Zomib is fairly common with proteasome inhibitors. So you saw carfilzomib, then you have Ixazomib. So this compound used to be called compound 9, and that's where the IX part comes from. And because it's an oral agent, if you reverse Ninlaro, it reads oral 9. So that's where the name kind of comes from. So it's oral 9 compound. It is currently approved in combination with Revlimid and dexamethasone for relapsed refractory myeloma patients. It is our only oral proteasome inhibitor. The dose is 4 milligrams taken once a day, so days 1, 8, and 15 of a 28-day cycle. Again, shingle prophylaxis is recommended, and blood thinners when it's being combined with Revlimid. Because of its route of administration, the side effects are GI side effects. So diarrhea and constipation may occur in patients. Low platelet numbers during the cycle tend to be a proteasome inhibitor effect that we see with bortezomib, Ixazomib, as well as carfilzomib. Peripheral edema, lower back pain, nausea and vomiting may also occur. But for the most part, these side effects are very manageable and happen in a lower percentage of myeloma patients. Coming to monoclonal antibodies, elotuzumab or Empliciti is an antibody that identifies a protein on the myeloma cell called SLAMF7 and then helps your own body's immune cells called natural killer cells go after those myeloma cells. It's currently approved in combination with Revlimid and dexamethasone. It's given intravenously once a week for the first 8 weeks and then every 2 weeks. Revlimid and dexamethasone are given in the usual fashion. Some patients may develop a infusion reaction, so some pre-medications are taken the first time that you're taking this medicine. So this combination of elotuzumab, Revlimid, dexamethasone, patients may develop some fatigue, GI symptoms like diarrhea or constipation. Patients have reported peripheral neuropathy, although the rates are fairly low. And there's a higher chance of developing upper respiratory infections. In some cases, I think we're going to talk maybe about supportive care later today. Some patients actually benefit from receiving IVIG while receiving this combination. The next monoclonal antibody is daratumumab, which again, is an antibody that targets a protein called CD38 that Dr. Anderson actually worked on back in the 80s. It targets that cell surface protein, and the immune system is enabled to go after the myeloma cell. And the way that the daratumumab and monoclonal antibody, the way it works, we're still learning how it works and how patients may develop drug resistance, but it's a little different from elotuzumab. It's currently approved for use with bortezomib, dexamethasone, with Revlimid dexamethasone, as well as with pomalidomide and dexamethasone in early as well as late relapse myeloma patients. Daratumumab or Darzalex is given once a week for the first 8 weeks, then every other week for the next 4 months, and then it goes on to once a month infusion from the 7th month onward. And there are pre and post medications that are given for potential infusion reactions. And one of the things that does happen, usually in the first cycle is an infusion reaction. It's a little more prevalent than what we would expect with elotuzumab. But if you're going to have it, it happens only the first time. So it's kind of like a one and done. So just like elotuzumab, we do see more upper respiratory tract kind of infections with daratumumab-based combinations as well. And we have to just be good clinicians and be mindful of that. So options at second relapse and beyond, this is an area I think I'm only introducing a couple of slides because Dr. Anderson is going to be addressing the immunotherapy piece of it. Dr. Keats is going to be talking about precision medicine. Both of those are extremely important talks, so just don't go away after lunch, stick around. When we think about, the second relapse and beyond options, pomalidomide is an immunomodulatory drug. It's currently approved in combination with dexamethasone. It's an oral capsule. The dose is 4 milligrams, and it's taken daily for 3 weeks out of 4 weeks. And just like with Revlimid or with thalidomide, patients are on blood thinners to reduce the risk of blood clots. Patients' side effect profile of pomalidomide is very similar to Revlimid. GI side effects, fatigue and weakness, low white blood cell count, a slightly increased chance of upper respiratory tract infections, and blood clots is there with pomalidomide. Farydak, panobinostat, my least favorite drug to talk about. It's currently approved for relapsed refractory myeloma patients in combination with bortezomib and dexamethasone. I'm saying it's my least favorite because of its safety profile. I think if we are getting smarter in how to give this class of drugs and combining it with the right partners, patients do benefit from this therapy. There are a lot of my patients who benefited, from panobinostat when nothing else was working. But the main side effects of this drug are GI side effects and fatigue, and those are the ones that get in the way of patients' quality of life. But I'm as I mentioned, being proactive, doing appropriate dose reductions, including appropriate antidiarrheal medications, knowing when to stop medicines, all of those things help in managing the side effects of this particular medicine. So there are some, general management pearls for proteasome inhibitors because patients, are at risk of peripheral neuropathy with some of these medicines. You have to be proactive as clinicians and as patients. Be mindful of tingling and numbness in the hands and feet, even if it's early. Inform your physician because that may lead to introducing different medicines that can mitigate neuropathy as well as some dose reductions in your proteasome inhibitor. With immunomodulatory drugs, being on blood thinners, depending on your risk of blood clotting is important. Glutamine for cramping, and then for GI side effects, many times, drugs like Welchol or, cholestyramine and cholestyramine can actually help patients. And then most of the immunomodulatory drugs tend to have a little bit of a sleepy effect on patients, so taking it at bedtime can actually help. For monoclonal antibodies, being proactive with pre and post medications for infusion reactions during the first cycle is important. For HDAC inhibitors, managing with antidiarrheal medications and keeping an eye on the EKGs because, patients who have, some propensity of developing heart arrhythmias, you have to be careful with giving drugs like panobinostat. What about second autologous stem cell transplant as an option? I think Dr. Krishnan covered this topic quite well. The only thing that I'd mention is that it's still an option that we consider for a subgroup of patients who are in their first or second relapse. Currently, we prefer giving maintenance treatment to patients until they cannot tolerate it anymore or until it stops working. So we want at least 3 or 3.5 years of benefit from that first transplant, in the setting of maintenance to consider someone for a second autologous transplant. Because generally, you get about 50 to 70% of the same mileage in terms of, disease-free period with the first transplant as you would with second. Clinical trials, always an option. It's, in fact, for majority of patients, they might be the first option. So always ask your doctors about, are there any clinical trials available for me? There are other promising therapies that are in development. Venetoclax is a BCL2 inhibitor. It works, quite remarkably specifically for translocation 11-14 patients. Selinexor is an exportin-1 inhibitor. It's an oral medicine that's in development. Pembrolizumab, there was an FDA hold placed on this checkpoint inhibitor, but specifically for its combination with immunomodulatory drugs like Revlimid and pomalidomide. There are some studies going on with pembrolizumab with some of the other myeloma medicines, so the story isn't dead yet. And then I think CAR T cells will be very well covered by Dr. Anderson, and there are a lot of other options coming down the pike. I believe, this is my second last slide, simply highlighting the different phase 3 clinical trials that are currently ongoing. I think we should have, we have taken off the pembrolizumab combinations here, but there are a lot of monoclonal antibody clinical trials comparing 3-drug combinations to 2-drug combinations that are in clinical trials. Some of them we hope will read out later this year, adding more options for our myeloma patients. So in summary, relapsed refractory myeloma is treatable. And the longer patients live with disease, we're adding more and more options. This is kind of a relapsing remitting course. This is where myeloma becomes a marathon. So, you're going to be on a certain therapy, it's going to work for a little while, and then you go on to something else. Talk to your physicians about commercially available options, talk to them about clinical trial options, and try to come up with a educated decision on what you want to choose as next therapy. And you can always reach out to any of the myeloma experts. There aren't a lot of us to go around, but we are here for all of you. And I don't think that any of the community physicians or the physicians that treat you would ever mind getting extra help in this very complex disease management schema, because the myeloma doctors haven't shared our dartboard with them. So, they don't have that. All right, thank you very much.
We have time for a couple questions, Saad. And there's a couple questions about the meaning of relapse. And patients following his M-spike very closely, and it's going up. When do you say that he has relapsed? And if he's relapsed, when do you say that he needs to start treatment again?
Okay. So that's a very loaded question. So in general, there are two patterns of relapses that patients have. One is a rapid clinical relapse where the M-spike or the light chains are going up fairly quickly, and the patients are also becoming symptomatic from treatment. And that generally is a no-brainer. You have to cytoreduce the disease and try to, get your patients in better disease control and better quality of life. The second category is the biochemical relapse or the slow relapse, in which, your patient is feeling fine, but the numbers are rising. And the decision making is partly based on disease biology. Even if you have a slow biochemical relapse where the numbers have gone up by 25% or more, but the patient has high-risk disease, generally most of us would be acting on that rise in the M-spike or the light chains in the high-risk myeloma setting. In the standard risk myeloma setting, where the patients are asymptomatic, the burden of disease is low, and the M-spike and light chain levels are low, if the doubling rate of the M-spike or light chains is over several months, we might actually watch patients in that situation and not pull the trigger, quickly. I think that is we can have a 1-hour discussion on this.
Absolutely, and that great answer. And the last question is: after multiple relapse, is there any benefit to trying an earlier regimen that worked well in the past?
Generally not, because the assumption is, as you've been through that therapy, if the myeloma cells have survived despite you receiving optimal duration of that therapy, then the likelihood is that those myeloma cells are resistant to that treatment. So, why would you try that again? In some ways, that concept is the same as, a bacteria developing drug resistant to a specific antibiotic. When you know that penicillin is not going to work for that patient, why would you use that? So, does that answer the question?
Yes.
Okay.
Thank you very much.
Welcome.